Hi, I'm Josephine Asiata-Tofaeono, and today I will be presenting to you folks wait times for veterans connecting with the primary care provider for an initial appointment at the VA Puget Healthcare System, specifically American Lake and Seattle campuses. What I will be covering today is my problem of practice. I'll be doing a review of literature, the need for data collection. We'll also take a look at the proposal for my project to include the methodology I'll use, participants as a part of my study, any anticipated access issues, as well as potential ethical issues, my positionality, and any outstanding questions I might have for folks. Thank you. So to get us started, my problem of practice is long wait times for veterans who are enrolled with the VA healthcare system, specifically at American Lake and Seattle, to get connected for an initial appointment with their primary care provider are a challenge. So we're going to take a look at our literature review. So some of the studies I found were pretty staggering. So wait times for appointments can be as long as ranging from 35.7 days to 60 days. Specifically at American Lake, that is VA wide. So specifically at my local VA, which is at American Lake, it can take 6 days for veterans whose care is already established and 42 days for veterans who are not yet established with VA healthcare. Some of the reasons for long wait times include tracking systems, VA's internal monitoring system used to monitor appointments. Research has indicated that wait time data from the VA's internal monitoring system underestimate reported wait times because they track wait times from the veteran's preferred date, not the initial request for services. And then another reason would be our VISTA scheduling system. So our VA's current VISTA scheduling system, VISTA standing for Veterans Health Information Systems and Technology Architecture, contributes to unnecessary delays in care. So research has found that that system that we use actually pretty widely nationally, it contributes to delays in care. So we're now going to take a look at a further review of literature and specifically attempted interventions to address long wait times. Some interventions to address long wait times are the electronic appointment reminder system, which results have suggested that appointment reminder systems may be associated with decreases in the mean number of days patients in the VA system have to wait for their appointments, but can also potentially lengthen waiting times for patients who miss their bookings. The next intervention that has been attempted is community care referrals. Studies suggest that there were no significant differences for community care network referrals or wait times and VA wait times. And third is clinical resource hubs, another intervention to address long wait times. Regional multidisciplinary teams that provide contingency staffing and specialty care to veterans, particularly those at rural or underserved VA facilities. That's what a clinical resource hub purpose is. There also was no significant difference in wait times that showed in studies that I found. And then lastly is the Referral Coordination Initiative. The VA in 2019 launched the Referral Coordination Initiative to improve the timeliness of appointments and veterans' choice of specialty care location. The study investigated whether the RCI, or the Referral Coordination Initiative, was associated with changes in the proportion of VA specialty referrals completed by community-based care providers and mean appointment waiting times for VA and community care providers. But it was concluded that in the initial years of the RCI program, RCI does not have a measurable effect on waiting times or community care referral rates. So now we're going to take a look at some of the gaps in literature. To better understand the gaps in the literature that I obtained, it's important to know and understand what research has been previously done at my local VA. And that is very, the findings were scarce. Scarcity of research findings, that's for sure. There was a news article that I had found on findings or studies that were attempted at American Lake in Seattle. However, it was a newspaper article that didn't appear credible, so I opted not to use that for for this particular presentation. And then it's important also to take a look at systems currently used. So systems currently used are community care referrals, electronic and paper appointment reminders. So there's a system for that as well to remind veterans of their appointments as they happen or as they're scheduled. And then taking a look at ways to improve times at the American Lake and Seattle campuses. So to do that, further research in electronic scheduling systems is needed, and then also further research in the effects of staffing. Because staffing, I've heard across the board, is an issue within the VA system, probably at almost most organizations in our country. However, that was one area that wasn't really emphasized in much of the studies that I had found. So that was one thing that I wanted to take a look at, was how staffing affects the wait times at American Lake and Seattle campuses. In taking a look at the need for data collection, the data I need to collect to address my problem of practice is a running history of records from the VA record keeping system for perhaps the last 10 to 20 years. That includes information about wait times and issues encountered with and for veterans at the VA. I also need to collect data directly from the veterans, appropriate leadership, and my colleagues at the VA Puget healthcare system. And this could be done by way of interviews and surveys. The methodology that I would be using or would like to use would be quantitative research. So through surveys in fixed response format, and then surveys to the veterans using a fixed response format to better understand patients' experiences firsthand, and then interviews using the Grand Tour questions format. Interviews with leadership and department employees to understand reasons for long waits at the local VA, and as well as to gather ideas for improvement. In taking a look at anticipated access and ethical issues, I may need to gain special permission and or clearance to access records and participants. So access to my research setting is at a low to medium degree. Some ethical issues may be power dynamics from leadership, facility leadership, my program manager, my direct social work service chief. So it'll be conversations that I'll have to have, or that I have had, to be sure there are no issues there. And then role duality, being that I will be, or that I am the research facilitator and the employee at the same time. That could cause some ethical issues. And then confidentiality and privacy. So participants may be worried or hesitant that their feedback will affect their professional lives, colleagues specifically. And also veterans may see my role as research facilitator and as a veteran, and that could cause some issues. At this time, we're going to take a look at my positionality. I identify myself as an outsider within. As her and Neelan suggest, some people are outsiders within, residing in the margins and observing the contradictions between the dominant group's actions and ideologies. Although I am a veteran who has experienced long wait times for a primary care appointment myself, I am also an employee who faces the bureaucracies of such a massive federal organization. While I may not agree with some of the actions and ideologies, I still believe in the overall mission of the veterans healthcare system. So, access to my research setting is at a low to medium degree. My social identities include being a United Methodist Pacific Islander, middle aged female, first generation college graduate, born in San Antonio, Texas, and raised on the island of Oahu, Hawaii. I have no children. My social identities can impact my assumptions and research approach by threatening the space of the people with whom I will be working. Attached is a list of my references. Second page of references. And lastly are the questions that I have posed. Number one, would it make more sense to focus on veterans with specific health conditions or just focus on veterans in general? Second question is, what other methodology could I best apply to best support my problem of practice and ultimately my research project? Would focus groups support my research project? And also, lastly, I am open to all feedback that can be applied to conducting my study and best direct my overall research project. Thank you very much, everyone. Take care.